Thank you, Dr. Mohan and the scientific committee for giving me this opportunity. Before I start, I think I should confess that all these new techniques that I've learned is from Amar. Amar has been a great source of inspiration for me. And I started Blue Dye Wells only after watching his videos. Thank you, Amar. So I'm going to show you three cases where we're doing an ab interno fixation of the dislocated IOL with two approaches. A 70-year-old male with a phaco foldable done 15 years back had a 6x6 vision. There was no history of trauma, but he complained of shaky vision, which is oscillopsia. And the only thing was that he had a pseudo exfoliation. You can see when his eyes are moving, the lens is also moving. So there is a definite zonulopathy with a lot of zonules absent. That's why it is moving so much. So we decided to go ahead and do an ab interno fixation, prepared the eye for a glued IOL. I placed a trocar cannula posteriorly. We can do an AC maintainer as well, but in this case, I did a posterior cannula. And see how easily the lens is coming out because it's almost all the zonules are absent. So while you're doing this, it's very important that to make sure that it doesn't drop into the vitreous. So gently you try to bring it out and keep it on top of the iris before you do any manipulation. Here I'm trying to remove the capsular bag. I tried it with cystitome. Now I'm using a vitrectomy cutter to remove the capsular bag. It's important that you free all the capsular additions before you do a glued IOL. So I'm trying to remove as much of the posterior capsule as possible. And now using the handshake technique, I've exteriorized one of the haptics. At the same time, holding on to the rest of the lens using the Y fork. And then again, once this is exteriorized, you can see the same handshake technique being used for exteriorizing the other haptic as well. And then there was no vitreous disturbance, but I removed the rest of the cortex using the vitrector, tucked into Shadid's pockets, as described by the Amar very beautifully. Did a very minimal anti-vitrectomy just to make sure there's no vitreous, and then constricted the pupil, and the case was done. So you can see the flaps are being glued. That's a great advantage, and I'm all for glued IOL because I did try Yamani. I'm really more satisfied with glued, but I think the whole world is talking about Yamani. I don't know why, because personally I feel this is really good. So you can see while you're moving, even the eye is moving, the IOL is well fixated. The patient regained a 6x6 vision without the obsolopsia. He was very happy. So now I'm coming to a very similar case of a 70-year-old female, of a male with a dislocated IOL back complex. But this time, this was a single piece lens. And he also had a pseudo exfoliation. You can see that, you can see again the lens is moving and you can see the haptic and the pupillary area. So, so what I'm going to do in this is I'm planning to do a Hoffman's pockets. Hoffman's pockets are created corneally, and then you create a scleral pocket going under the conjunctiva, and then through the roof of the pocket, you introduce a 26 gauge needle, and you retrieve the Prolene suture by docking onto the 26 gauge needle, both superiorly and inferiorly. And once you get both the haptics, you can you can retrieve the sutures and go ahead with the tying the sutures. Here you can see that I'm making two clear corneal incisions about 300 microns deep, and I'm creating a pocket. Sometimes there can be quite a lot of bleeding. That's the only problem with this procedure. Just check to make sure that you have enough of the pockets, making two side port incisions. And then now 26 gauge needle is going through the pocket and it's going under the haptic of the lens. And it's retrieved. Again, the second portion of the needle is now going through the side port and then being again docked onto the needle, and it's pulled out. So now one side, the loop is inside, and you can see the lens moving nicely. And you can retrieve the sutures from under the pocket and keep it aside before you tighten it, because you need to make sure it is in the center. You keep it aside and then you move on to the other side and do the same. So here again, you can see now it's going, you can see more clearly that, see the 26 gauge needle is docked and the 10-0 polypropylene is inserted to that. It's railroaded, and the one above and one below the haptic. Like Dr. Malugan was saying, I think these polypropylene needles can actually degrade over time, and probably it's better to switch over to Gore-Tex in the future. You can see once you've titrated, made sure that the lens is in the center, you can go ahead and tighten it. Make sure you don't tighten too much towards one side, and then the case is over. So that this is a third case of a dislocated multi-piece IOL. So the patient has had a PCR, and the surgeon had put it just into the the superior portion. He has just hung it onto the PI, and so the patient was totally dislocated. It had come down, so it removed the lens from the iris or from top of the iris. And again, here the handshake techniques helps a lot, because then on both sides you're able to catch hold of the iris. Now I'm doing a minimal vitrectomy to remove all the capsular contents, and here using the handshake technique, we can see that the haptic is being presented. So both sides, the haptic is retrieved. In this case, you can see that I've used an AC maintainer. And once you've retrieved it, just center the lens nicely. Just make sure, like Amar said, there's no pupillary capture. Don't over tuck the lens, because then you might land up in problems. So just tuck it enough, just enough, say about 2 to 3 millimeters. Inside 2 millimeters should be fine. And then inject air. I always inject air just to make sure that we're not having any pupillary capture, and also to make sure the pupil is round and it's not tucked in anywhere. And then the case is completed. So all three cases were managed ab interno with totally this thing. So I'm just going to show you, since I have time. I have case who had a 45-year-old female, AC phakic IOL done 15 years back. She had trauma with a tennis ball, sudden drop in vision, dislocated IOL, with a phakic IOL with a Ured-Zavalia syndrome. So this case, one part of it was at least already disenclaved, as you can see. So the other portion, I gently disenclaved from the iris, rotated the lens, and this was a rigid lens done about 15, 20 years back, the Verisace model, and removed the lens and sutured the opening, went ahead with the phaco, because this patient had already developed cataract also. But I think this was not due to the trauma, but she developed a cataract, must have developed a cataract over a period of time, and she landed up with us because of the trauma and sudden drop in vision. And unfortunately, during this time, she has also had a Ured-Zavalia syndrome, and the pupils were not going down even after injecting pilocarpine. So you can see that the case has gone on very well, very nicely, and injecting because she had a very high myopia, somewhere around -3, and had to put a multi-piece IOL. So I tried to see whether I can do an SFT for this patient, but the iris was quite stuck and very fibrous. So I decided to do an iris encirclage. So this is probably my first case, and if I do it next time, I may alter it a little bit, in that sense that probably I will put more, tuck in more number of times. So what I've done is I've done it a little bit farther apart, and the superior portion where I've sutured actually was very fibrosed, and it was every time I was trying to tuck it in, it was tearing. So that's the reason why in one area alone I was not able to take multiple sutures, but went all around. So it's important that you take multiple side port incision to facilitate this. And once it is done, you can just tighten it and tighten it as much as possible. You can see that one area alone I was not able to tighten properly because of this cheese wiring. So, but ultimately she did well, and she said after a long time, you can see that the pupils are pretty normal except for the superior portion. What her this thing was feedback was, she said after a long time I'm able to go out in the sunlight without wearing sunglasses, because this, I think she's had the Ured-Zavalia during the primary procedure itself. So I'd like to thank once more for the great opportunity. Thank you.